I think the number of people that have signed up to today is really testament to how much this is on people's minds at the moment, and how important it is, how important a subject it is. And I know that lots of conversations are happening in local systems. So just I just want to clarify a little bit about what today's session is, how it's going to run through a little bit the speakers that we're going to hear from. So just to introduce myself quickly, I'm the Programme Manager for Personalised Care and Social Prescribing at Healthy London Partnership. And today we're going to be talking about how to use your ARRS roles, your Personalised Care ARRS roles specifically, in an effective fashion. So it's got a positive benefit to your patients, to the communities that they live in, and obviously your surgeries, your practices, your PCNs as well. So I think the other thing to say is today's session is going to be the first of several looking at this topic. I hope Healthy London Partnerships convene a bit of a regional network across London. So we've got 5 ICSs in London, and what we're trying to do is identify some of the themes that are pertinent to all across London. There is real value in us all getting together. Today I'm going to put up I don't know whether or not somebody can launch the poll for me just to find out who's in the room. But I suspect it's a real mix of CDs and social prescribing advocates, people that are working on the front line themselves, commissioners, people that are concerned with the development of social prescribing and the broader personalised care agenda. So it's really important to bring multi-stakeholders together to talk about some of the opportunities, the challenges and opportunities that face us. And to share some best practice, to identify some innovations that are happening, and share some learnings where in bits of the system that are a bit further ahead than the others. So due to numbers today, if we could go to the next slide, please. And I think it's important to say that this by no means will, that we hope that this will support you in the conversations that you're having in your local systems, and by no means is a replacement of that. So we've got a huge number of people today. I'm just thinking, has the poll been launched? If somebody could, oh, here we go. There we go. I've managed to launch it myself. So if you could answer that poll, I'm just curious to know who's in the room. It's good for us to know who else is in the room. So due to numbers, it would be great if you could all stay on mute. We've got a Slido up and running. So we're going to be hosting a Q&A later on in the session. And this is a really great place for you to pose your questions. If you hover your phone, the camera on your phone over that QR code, it will take you through on your phone to the Slido. And you can pose questions there. You can see questions other people have asked and vote them up. And yeah, we'll be hopefully, this is a nice democratic way of understanding what people are wanting to know in the room. So we've got, it's also a really informal session. Feel free to use the chat to talk to each other, to share resources, to comment as we're going. It might be that we pick out some questions or some observations that are pertinent to the speakers at the time, just to get further comment. So feel free to use that as well. We're going to hear from Jagan, who is the clinical personalised care lead for London, and Nick Gitcham from NHS England, who's head of social prescribing at NHS England. We're also going to hear from some practitioners and people that are managing the health and wellbeing coaches and the care coordinators, to hear about the ways that they are using the roles. We're going to hear we've got a couple of examples in practice of people that are using all 3 roles, and then hear a little bit about what support is available to us in London. And then we'll have a Q&A with everybody that has presented. But I'm aware that there are some people in the audience as well. So if we have chatted before and you are somebody who I know is a bit of an expert on this in this field, then don't be surprised if I check in and see if you might want to answer a question. So welcome everybody. I'm going to hand over to Jagan to kick us off. If we go to the next slide.
Great. Thank you, Leanna. And thank you, everyone, and welcome to this session. We're hoping the beginning of a number of sessions to support you, people on the ground, with your work on personalisation within your PCN and wider, and also really to help and get some feedback in terms of difficulties you may be having. So on this call or this webinar, we have some of our experts, but also we have some of our colleagues. We've got our clinical leads for each ICS, which is the integrated care system, who are there to kind of support each of you within your integrated care systems. And some of them will be presenting today, and also they're available for any additional questions you may have regarding your particular circumstances. So we hope this will be a really helpful session. Certainly as a team and across London, we're very committed to personalisation. We're very proud of personalisation. And we've got a fantastic team and management teams, not only in London as a region, but also through Healthy London partnerships and, of course, within our integrated care systems across London. So over to the next slide. So, you know, what is this all about? Well, personalised care is about giving our residents and the people that we serve choice and control over the way their care is planned and delivered. So it's a holistic approach about what matters to them and embracing their individual strengths and needs. And person-centered care is really embracing the whole psychosocial model as a whole, to help not only to support themselves, but their diseases or even their conditions that they may be, you know, unfortunately having. Just to make people aware that London, we have committed this with the long-term plan. We are very much putting in place that by the end of 2020 to 21, we'd like to have more than 1,000 social prescribing link workers, and that rate going, of course, increasing by 2023-24. And the aim is really to help serve 900,000 people across London, and of course making them feel connected to the wider community assets and those services. And of course for London, what we're talking about, well, roughly we're talking around 800 social prescribing link workers by 23-24, which approximately, is around 4 per PCN, with an average population of 50,000. So we really are committed to expanding the social prescribing model, as well as our two and the other personalised care members of the PCN team. And it is part of the London Mayor's GLA COVID recovery plan and the London Vision. And this is really about that place-based care, which is about working at a neighbourhood level, taking the assets-based approach across London. Next slide. So why is it important for us? It's just really that 5 of our London boroughs are in the top 10% of the most deprived boroughs, and personalised care is an intrinsic tool for PCNs in that community recovery. And of course, one of the things that we all need to do collectively as leads and as members of those PCNs is to really make sure that our PCNs are serving our local population and ensuring the roles that we are kind of embracing are not only embedded in the PCN, but are used for the population needs. So currently across London, we have around 300 social prescribing link workers, and what was fantastic about London was the fact that we had a huge appetite to grow more social prescribing link workers through initiatives that are about to follow. And several examples of how our ARRS is being used to innovate to fund specialist social prescribing link workers were, for example, interest to do social welfare legal advice, link workers to focus on children and young people, looking at kind of lead social prescribing link workers to support each other, link workers to things like violence reduction. So some real fantastic, very much population-based needs. And of course, the data being collated on the number of those, you know, for example, care coordinators and health and wellbeing coaches, we've got approximately 15, around 20. But I will say one of the biggest issues we've had across from a region is we don't really have an accurate set of numbers because of those. The workforce returns haven't always been complete, and I understand, of course, there will be pressures. So it's something that we need to address together. But what is clear is that we seem to have very few PCNs that have all three roles that are active. Whether that's true or not, I'm not 100% convinced, because I think things have changed considerably. But remember, we're getting this from the data set that PCNs are sending to London. What was really interesting is that if that's the case, and if there is some truth in that, I think there is a significant amount of staff and that ARRS underspend in London. And of course, that is available, and it's important for us collectively to support you to try and say, look, the team, the NHS England have given us this funding and this support, and you know, how do we address and try to get these posts filled in? And of course, one of the things that we obviously need to address is understanding the community and the pressure within the community in terms of primary care workload, and of course that community recovery, and of course how, you know, we'll see today about using these roles to help support not only our patients and community, but also GP practices going forward. The next slide. So I'm not going to say too much. You're going to have some fantastic speakers today to try and really talk to some of what they have felt, and of course hear from some of our leads. But you know, we would love to help, we'd love to support you, so please, you know, get those questions going in, and of course we will send the slide pack, and of course we're happy to answer questions offline as well. So I'm going to hand over to Nicola Gitcham, who's our head of social prescribing for NHS E and I, and a real support for us in London. So over to you, Nick.
Thank you, Jagan, and thank you for your leadership. I think London's really showing the way on how to develop that regional support to help people on the ground to really make the most of these roles and help use them to deliver personalised care in primary care and tackle health inequalities. So it's great to be with you this afternoon. We're here to help as a national team as well as the regional teams. I know you're putting questions in the chat today. We'll answer as many as we can today, but if not, with Leanna and Billen and team, we'll go away and get you the answers and certainly feedback anything that aren't working at the moment that we need to be thinking of in the future. So really fantastic to be with you this afternoon. So I've only got 10 minutes, I'm going to be 8 minutes, I'm going to be very, very quick. So I'm going to give you a very quick introduction to personalised care. So Jagan's talked a little bit about this. I think it's really important to understand these roles in the context of the big transformation that's happening within the NHS as a whole, and how these three roles can help primary care to deliver personalised care. So personalised care is one of the 5 key practical changes for all integrated care systems, health and care systems, over the next 5 years. It's a long-term plan commitment. Universal personalised care was the document that gives a lot more information about it. But the ambition in the long-term plan is that personalised care will reach 2.5 million people by 23-24, and at the moment we're about 1.7 million people. And social prescribing referrals and all the activity in the other roles adds to this. So it's they really can help to deliver this. So where did the personalised care model come from? Well, I think it's really important to remember that personalised care came from people themselves. So the independent living movement by disabled people had a huge role in shaping public services and helping them think through how they would work with people so that people had better agency, better choice and control, better connection, but also so that we actually build on the assets and the expertise that people bring themselves and that are in local communities. So it's a very different way of building a new relationship and is a key transformation driver for the NHS and for integrated care going forwards. And over several decades, the various components that make up the model, which I'll go through briefly in a minute, have delivered evidence to show they can really help to improve people's health and well-being and create this culture change that we need to take, exactly what Jagan says about a more holistic biopsychosocial approach. We know medicine has its place. COVID, with the vaccination, has shown us some of the really important things of why we need medicine, but it's not enough in itself. And we know that because of the how social determinants of health, such as being out of work or having relationship issues or housing issues or money, stress and poor education, all of those things, how they impact on our health and well-being. So if we really, really want to develop strong neighbourhoods that promote health and help people's health and well-being, then we really need to attend to a much more holistic approach that addresses social determinants of health as well. So the personalised care model is made up of a number of components. So the first one, you could say, is shared decision making. So this is how does every clinician in the NHS have a different conversation with people that starts with what matters to them as well as what's important for them. And it's about how you share information so that and make decisions together so people are really part of the decision making process. And that enables us to deliver those legal rights of choice, which is the next one. Another component of the comprehensive model is something we call shared supported self-management. So this is how can we help people have the knowledge, skills and confidence to really manage their own health and well-being. And I would say with link workers, help people take more choice and control over their life and feel much more in the driving seat, particularly when things are complicated and they've got lots of challenges facing them. And so the sorts of things we look at here are health education, health coaching approaches. So you can see with the social prescribing link worker and the health and wellbeing coach, they certainly play that role, and connecting people to peer support. And then you've got social prescribing, which I'll talk a bit more about in a moment, but that's obviously about how we actually really focus on some of those more complex social issues that are affecting people's health and wellbeing, and use solutions other than medicine to help improve give people more connection, agency, and purpose, so reason to get up in the morning. So really playing into helping people with experiencing mental health difficulties. So such as nature, arts, and exercise and things like that, as well as the practical advice and support. Personalised care and support planning. So we have numbers around personalised care and support planning, but all of the three roles would be carrying out a personalised care and support plan. And that's a different type of care plan. It's really focusing on what matters to the person and their person-centred outcomes, as well as the evidence-based support of what's going to help them to achieve those things. And then lastly, but not least, is personal health budgets. And personal health budgets, I think, is the system's ultimate test in supporting people to have choice and control over their lives. So this is when people can use money that they would normally have got for services in a more creative way and have more choice over how that might be used to be able to achieve the outcomes that are agreed between them and the clinician. So in social prescribing, we see small personal budgets used to help people access community activities, but often the packages are more around continuing healthcare or Section 117, so things like that. So if I can have the next slide, please, that would be great. Thanks, Liana. If we can just move on. So social prescribing link workers got some really important roles. So they can spend time with someone really getting to the bottom of what are the underlying issues and helping to connect them to a range of community support and statutory services. But they also play another really important role, and that's more around community development. So they can identify and nurture community groups. They can work across all the statutory and VCSE partners to really have a good understanding of what's available. And so they can really help with that proactive approach to addressing health inequalities, getting to know communities, understanding what's there, as well as actually seeing people on a one-to-one. And particularly works for people with long-term conditions, people with mental health needs, people who are lonely or isolated, which we know has gone up during the pandemic, and particularly around young people, and complex social issues that are getting in the way of their health and well-being. So if I can have the next slide, please, Leanna. So we know that, I think what is really important is that this isn't something that's just nice to do. It's actually well embedded in the strategy of the long-term plan, in the Conservative manifesto, but also within the DES guidance and contract and the IIF. So it's part of the way we are using to transform the NHS and to help build those relationships with local communities and support people to have a much more holistic approach to helping their health and well-being. And at the moment, from our soft count, we've got about 1,800 link workers across the country. Take up varies enormously from none to 10 or more. So in the more mature areas and the areas where they're really getting to grips with health inequalities and really thinking creatively how they can reduce pressure on general practice, that's where we're seeing the teams of link workers growing. And I'll talk a little bit more about that at the moment. But of course, the PCN DES for the last year was that by March this year, every PCN would have access to a social prescribing service. So if we can go to the next slide, please. So Jagan, it was really fantastic to see your ambition in London and to see the various ways that people are using social prescribing link workers. But one question I often get asked is, how many do we need? So I think the first thing I would say is, you need enough to meet the needs of your local population. You know, who is it that you're trying to deliver this service for, and who are the people that perhaps would benefit from this that aren't in contact with you, that might end up in A&E or coming in through crisis as well. And I think it's absolutely critical, as we're at this stage in the pandemic, that we start rebuilding the link workers role. So during the pandemic, link workers did a really valuable role with wellbeing checks to people who are on the shielding list and everything, really, really important. But now we really need to rebuild that role. What we know from the evidence on social prescribing link workers services so far is this works when link workers have time to spend with people to really get to know them. So we talk about up to 6 appointments, but really being able to help people access community groups and support as well. But also when they've got the time to get to know the local community, identify what's there, understand the other roles that are like them in the system, and really be able to add value to your practice, to being able to help people connect quickly. So the first thing is enough to do the full role and enough to meet the needs of your local population. And absolutely, our ambition for the long-term plan is 3 to 4 per PCN. And Jagan, really great to see that you're, aiming for that 4, because I think that's when you really get the benefits. So in addition to generic link workers, what we're seeing around the country is those more mature areas are developing specialist roles as well. So they're really looking at who they want to be able to really reach out and serve better. So children, young people, link workers, and we've seen some fantastic stuff in Lambeth happening around this. Children, young people's world is very different to adult services, and so it really helps to have one that is specialised on children, young people, attached to schools, attached to children mental health services. Really seeing some fantastic work there. The other way we're seeing specialism is around particular issues. So we're seeing a lot where they're specialising around welfare advice, and you've got a good case study of North Islington that Liana and others can signpost you to, but really particularly where there's high areas of issues with income and housing and whatever. Other areas, Islington, we're seeing some great stuff around specialisms, around particular cohorts of people. And we've got some webinars around each of these that you can have access to, and also reaching out into particular BAME communities. So, and then in addition, where you're having a link worker that takes more of a managerial role over the link workers, but potentially the other personalised care roles as well. So I think good questions are, where is there pressure on your practice that a link worker could help with? What are the needs of your local population using population health management, soft intelligence, and how can you use these roles to address health inequalities? So what we need to do is move from not just link workers taking referrals to whoever's referred in, but actually a much more proactive outreach and targeted support to really reaching out into communities that have, where we've seen through COVID, it's been exposed that those health inequality gaps have widened. And I would encourage you to work with your ICS partners to really start to look at how you develop strategic planning for social prescribing and community activities at a place level, so that you know the needs, you know what sort of activities are out there, and you can identify the gaps and work with the voluntary sector, charitable funding and others to be able to address those gaps in provision. So if we can just go to the last slide, and this is my last one, Leanna. So just to say, I've talked about social prescribing, but it's been fantastic to have these other two roles come in. So all of them focus on what matters to me. All of them use personalised care and support planning. Your link worker and your health and wellbeing coach will have expertise around using health coaching approaches. Your health coach will be your expert, and they'll have more dedicated time for people that want to work on specific health conditions and getting to grips with their diabetes or things that they, you know, really want to do more on. And your care coordinator is really helpful for people who have many agencies involved in their life and need a bit of help to navigate the system across health and across social care. So they work together. We've advised a single referral point that can be through the link worker. We've said that just, or the manager link worker. We've said that because every PCN has to have a social prescribing service. So that's the one thing we can say, but it's for you to really determine. And I would just encourage you, and we'll probably get this in questions, to really make sure that they're part of the multidisciplinary team. That's how you'll get the best out of them, that they've got access to the IT system so they really can code for you and they're part of that team, that they have the right supervision and support. We can talk a bit more about that later if that's helpful. And that you really work with your ICS, with the training hubs in HEE and with other PCNs to think how you can address some of the issues that are coming up. We're here to support you, very keen to support London. We're very excited about social prescribing work in the capital, and you've got the regional team too. So that's all for me from now, but great to be with you today. Thank you.
Thanks so much, Nick. Super helpful to get a bit more of an in-depth understanding of social prescribing link workers. I've seen some comments around, you know, why would we get specialist link workers when there's services out there already? I think the point to make here is that there is, as Jagan was explaining, there is additional roles reimbursement through the DES contract that will pay for these roles, and there's an underspend at the moment, and so it's about bringing resources from health into the community, and these roles can be embedded within the community. They will be managed. So for example, the citizens advice, the social welfare legal advice, they would be embedded within a citizens advice service. So what we're trying to do is bring funding from health to bolster and capacity build the community services. I can't take Nick off spotlight. I don't know if somebody else can.
Leanna, can I just say something about that as well? I think that's why we are so keen on place-based approach to this as well. In the DES guidance, it talks about a shared plan, and what we really mean is that you look at what the needs of the local population, you understand the local ecosystem that you're operating in, and where's the biggest opportunity to add value with this additional roles money, and really looking at how it works with other bits of the system. You know, we've seen link workers being based within multi-agency teams that are around safeguarding to be able to take a much more preventative approach, and lots of things like that. So each local system will be different, but it's really understanding the needs, working together and looking for how you make the most of the opportunity and the funding that's available.
Definitely. Thanks, Nick. I wanted to just walk through this slide very quickly. Many of you in the sign-ups were wanting clarity around the 3 roles, and I think the two next speakers that will be going into a bit more detail around the health and wellbeing coaches and the care coordinators, I think will really illustrate this slide. But this is going to be there for the resource pack that goes out, and hopefully it really clarifies and can be a very good tool for putting in front of people within your surgeries that might be making referrals and trying to understand who they should be sending somebody to really understand where to go first. So I'm going to hand over to Caroline Haim, who is a health coach and has been a health coach in East Merton, and she's going to talk us through the role that she's doing. Kerry, if you could skip 2 slides to Caroline's introduction.
Hello.
Caroline, are you there?
Yeah, can you hear me?
Yeah.
Yeah, excellent. Hello, so I'm Caroline Haynes and I'm a health and wellbeing coach at Londoncentric.
Caroline, your sound's going in and out a little bit. I don't know if there's have another go.
Is it a bit better if I just sit a bit closer?
That's much better, yeah, thank you.
Got my face in massive screen, so apologies for that. So I'm the health and wellbeing coach at Wideway in East Merton PCN, and I've been doing this role since the beginning of the year. So I work here 2.5 days a week, and 1 day a week I work as the regional mentor for health and wellbeing coaching in London. But I'll talk about that role a little bit later when we come to the support section. So since I've been working at Wideway, I think we've developed a relatively robust way of working. That's not to say that we're not still trying new things, but how I tend to work with patients at the moment is I work with them over a number of sessions and I help them to achieve a health goal. So the feedback I've got from patients is that it's a very different conversation than they're used to having. So whereas they might have a conversation with the doctor, which is the doctor diagnosing them with what's wrong and telling them how to fix it. And whether they can do that or not, sometimes obviously people can't manage to change their diet, or they can't manage to, they don't take their medicines. The health coaching conversation is very different, and it's really working in a partnership with the patient and asking them what matters to them and what they've tried in the past, what they want to achieve, what barriers are in their way, and what changes they're willing to commit to making. So at the moment, I primarily work with obesity patients, and that's the cohort that we decided to target. It's a very deprived area, and we've got a lot of obese and diabetic patients with very low levels of activation. So they were the people that we decided were would really benefit from this. So I probably see around 60 to 70% of patients who are obese. A high proportion of those also have mental health challenges too. And then I probably see around 20% of patients with just mental health challenges, and then a handful of patients who want to give up smoking or alcohol, or I also see some people with chronic pain. I've probably seen around 100 patients so far, and I've got around 30 on the waiting list. And because we've got a relatively large waiting list, what I'm hoping to try soon is doing some group coaching, so we can see more patients basically. And I guess what I've seen with some people that have got diabetes is that we've got some people who have got low education levels around how to eat to help their condition, which I think would be really good to have in a kind of group coaching scenario. And then kind of some patients who know how they want to eat and know what they should be eating, but they just kind of can't get there due to emotional reasons mainly, and those people are the people that I think would really benefit from one-to-one coaching, which is what we're doing. So, we've still got some work to do to probably optimize the model that we're using, and I think that will be an ongoing process. We've got a good referral pathway, so generally, the GPs and the nurses and other clinicians refer on to me. We've got a referral form on EMIS that they fill in. It's really easy, really quick. And then they send me a task, and then I'll call the patients up. I'll tell them a bit about health and wellbeing coaching. and I will book them in for me. So yeah, so that's a quick summary of health and wellbeing coaching in East Merton. Can we have the next slide, please? Who I'm handing over to.
Caroline, just where do you find that it's not working so well?
There's some patients who there's language barriers. That doesn't work too well. And then I would say I have the least success with patients with chronic pain. They're quite difficult. And probably people who want to give up alcohol and smoking. I mean, those patients are probably much better suited in specialist help, but for whatever reason, they don't want to get specialist help. So they're not particularly committed to making the change. And I guess the other kind of area where it doesn't work too well is people. I have quite a lot of people, probably, I don't know, 10 to 15% that turn up to the first appointment and then they don't come back, and they never come back. They kind of realise that it's not really for them, or they're not committed to making the changes, and then they don't come back.
And what training do you think is, have you had any training that you found particularly useful? What training do you think is useful for health and wellbeing coaches?
So there's a 4-day training. So I qualified as a health coach before I started this role. So that it's not necessarily, which obviously gave me lots of skills in terms of health coaching. But I would say when you're recruiting health and wellbeing coaching, it's not they don't necessarily need that qualification before they start. On the PCI website, I think there's a number of different training courses that are accredited. They're 4-day training courses. I think there's kind of 3 or 4 providers of those. That training is really key, I would say, to any health and wellbeing coaching starting, whether they've got training in it beforehand, just to make sure that there's that consistency across all health and wellbeing coaches.
Fab. Great, thanks so much, Caroline. We're going to hear a bit more from Caroline later, as she's one of the mentors supporting health and wellbeing coaches across London. Let's go to Janie. We've actually, London gets accused of being very London-centric, and we can see that there are some really fantastic examples in other bits of the country. Why not bring them in to show London how it's done? Janie's working in a massive PCN in a very deprived area, and they have a population of 250,000, and so they have really big teams of care coordinators, health and wellbeing coaches and link workers working together. So if we could remove the spotlight from Caroline and go over to Janie. There she is. I'll hand over to you, Janie.
Hiya everybody, I'm Janie Wyke. I'm one of the PCM managers over in Barnsley, and I lead on personalised care. So as Leanna says, we have got quite a big PCM, so every GP practice in Barnsley is signed up to be part of our PCM, so that's all 32 practices. We have got a population size of 293,000, so there is a lot out. We have got a big population size. We've also got every practice in Barnsley's got a care coordinator embedded in the practice, as well as a health and wellbeing coach. And we've got our PCN split up into neighbourhoods. So we've got 6 neighbourhoods, and each neighbourhood has got at least 2 social prescribers attached to that. So we've got quite a big personalised care team across here in Barnsley that we're sort of really invested into. So the care coordinators, embedding them in practice was a real good move. So they've got a real understanding of the patients. So they've spent a lot of time with all practice staff. So they spend a lot of time with reception, GPs, identifying the needs of the patients in their practice. So we found that there's a lot of crossover between the health and wellbeing coaches and care coordinators. So when we implemented them into practice, my first task was to really separate the roles so everybody were clear on who's doing what. So we separated the roles. I started my job as a lead social prescriber and then progressed to a PCM manager. So it was something I was really passionate about. So the care coordinators, they do a lot of the work across the SPEC and the Impact and Investment Fund. So enhanced health in care homes, the care coordinators in each practice are the main point of contact for any care homes that's aligned to that GP practice. We found this has worked really well. It's freed up a lot of reception time. So where receptionists were getting a lot of phone calls from care homes, they're now finding as they've got a main point of contact and they have a contact that they can get to daily, then they're not ringing, the care homes aren't ringing as much. So that's really helped. The care coordinators are also helping with working with the frailty nurses and community matrons to do personalised care plans for residents in care homes. We're finding that's working really well as well, because the care coordinators can spend a lot of time with the care home residents and really find out what matters to them, doing a really person-centred approach to the care plans. We've got, although anticipatory care hasn't come in yet, we are doing a lot of work with care coordinators on anticipatory care. So care coordinators are spending a lot of time case finding patients at risk of becoming frail, identifying them and then referring them on to appropriate services to try and avoid hospitalisations or having to go into care homes. As well as that, the care coordinators are doing a lot of work on the early cancer diagnoses. So we've trained them all on behavioural insights. So the care coordinators will adjust the letters that they send out to patients to try and encourage them to come in for the screening appointments. They're identifying non-attenders and making personalised phone calls, making it a little bit more personalised, finding out why they're not coming forward to their appointments, and re-educating them on the importance. The care coordinator is doing a lot of work on See the Signs, which is a tool we use up here. So any patient that's referred on to a 2-week wait, the care coordinator follows them through all the way through the referral process and right on to living beyond cancer. We found that it's really helpful that when somebody is diagnosed as an early cancer diagnosis, they're finding that one person has been a point of contact really helpful. It's helping with anything they need. They can go to care coordinators. If the care coordinators don't go to know the answers, they know where to go, and then it's the patients they are referred on a 2-week wait aren't feeling like they're on their own. They've got that support through the treatment. The care coordinators are also linking in with care navigators up at Barnsley Hospital. So at any time through a patient's 2-week referral, they'll know what stage they're at and can get any information that patient may need to what's going to be happening next, what are they working with. So our care coordinators work really closely with our health and wellbeing coaches and our social prescribers. So the care coordinators are case finding, so they'll identify frequent attenders, they'll have conversations with that person, find out what matters to them and refer them on to the appropriate service. So for instance, if they're having problems, they're wanting to lose a little bit of weight or they're having problems with a lifestyle, they'll refer them on to the health and wellbeing coaches. If it's isolation or anything else, housing problems, they can refer them on to social prescribers or work with the social prescribers to support that patient. They're also doing a lot of work on the learning disabilities. So in Barnsley, we didn't have a lot of patients on the learning disability register coming forward for the learning disability assessments. So care coordinators are doing a big push and spending time getting to know their patients in the practice who are registered. And then we're finding that these patients are now feeling comfortable and are quite happy to come in for their annual reviews. So yeah, that's sort of how we're using our care coordinators in practice. Types of people that we've employed in the role, obviously we've got 32, well, I think it's about 30 full-time equivalents. So we did a big recruitment campaign. We found we got a lot of people coming forward. So not only we a primary care background, we had a lot of people who had a lot of front-facing patient care, so dental nurses. We've got people who used to work in care homes. They've all come forward and we're finding that they're really good because they really understand the patient's needs. They've spent a lot of time trying to help patients. So a care coordinator doesn't have to come from a primary care background to make a success of the role. Like I've said, they work really well with social prescribers and health and wellbeing coaches. They work as a team in each practice. They attend MDT meetings. So they're a real key member of the team. And top tips that I can give you for making a care coordinator's role successful is communication. So when we first implemented embedded the care coordinators, it weren't 100% sure. We didn't know where the role were going. So some of the care coordinators helped out on reception a little bit. So I think before you embed them into the role, it's really good to find out exactly what you want, what your practice managers want them to do, what they're struggling with in practice, what capacity they've got. So we spent a little bit of time after we got all the care coordinators working out actually where are the struggles in practice and what can these people do to help you. So it has been a massive task, but I think we've just about got there now. So all our care coordinators are all working in practice and really helping with personalised care. So yeah.
Janie, it's so wonderful to hear the journey that you've come on, and when we spoke before, it really struck me the impact you were illustrating on the surgeries by having the care coordinators being the first point of contact for the care homes, and how now the surgeries are freed up, the receptionists and the GPs alike are freed up because that care coordinator can be the first point of contact. And obviously they can give time to those to the once a week ward rounds. You've given us so much information there, and I think it's really interesting. Obviously Nick was talking about one point of referral, and it sounds like although social prescribing link workers and health and wellbeing coaches will receive direct referrals from the GP, that the care coordinators in doing the case finding, using the Eclipse dashboard to do that case finding, they can be a bit of a triage for those other two roles. I think it's absolutely fantastic. Thank you so much for coming along today and sharing that example. I think there's lots in Janie's, there's lots more to Janie's example that I think we're hopefully going to capture in a case study, because they've got all three roles working together really well. We're going to move on to looking at some of the examples in London where all three roles are working. If we could go to now Dr Noede Canlodi, one of the GPs and clinical directors in Walthamstow West in North East London. Are you there?
Yes, I'm here. Can you hear me?
Hi, lovely to see you. Yes, I'll let you tell your story.
Sure. So I'm going to give you a brief journey of our process involving the three health staff that we talked about, and a few top tips at the end. So basically, we're a group of 5 practices based in central Walthamstow. Our experience of social prescribing was limited. One of the practices had referred quite a lot of patients to the local authority social prescribing service. 2 practices, including mine, had referred only a handful, and 2 practices had never referred a patient to social prescribing service. So we go back to April 2020. So April 2020, if you remember, we're in the midst of COVID. Our surgeries are closed. We're struggling with our phone lines. Everybody's having difficulty. At that time, our 2 social prescribers were due to start. So we had 2 social prescribers who we had hired on a job share. And I remember thinking before they started, this must be the worst time for them to start. How will we have the induction? How will they see patients? And boy, was I wrong. Actually, it was the best time for them to start, because at that stage, we started getting the laptops coming into practices, and straight away, we got them involved in remote consultations. So I did a quick session with them on EMIS, set them up on working offline, on working from home. And straight away, they started looking at our high-risk patients. And we realized, rather than just calling up the patients and making sure they had received the shielding letters, they were going beyond that. They were making sure the whole family had the support they needed. They were making sure that the carers had the support they needed. Also making sure that food parcels were being developed. We started to get such amazing feedback, both from families and patients. We realized this was an untapped resource, which we hadn't been aware of. It was an unknown for most of us, but actually we realized it had a huge amount of impact on our patients. So as time went by, we moved on to other patients. So we started referring patients directly to social prescribers from practices, as well as high-risk patients, as well as patients who were frequent attenders or frequent phone callers, as it happened. The feedback we had from patients was incredible, which was great. So patients were getting the support they needed, but also we started noticing that the practices were so impressed with the care that the social prescribers were giving. So as an example, in my practice, we had a patient who's in his 70s who was basically calling the practice about 15-20 times a month, either calling the practice, or the next morning you would get a call from 111 to say, can we call him back? So we referred him to the social prescribing service, And initially, the calls continued, and also they were calling him on a regular basis. But gradually, they had a plan for him, and we started to notice a reduction in the number of calls, which was great. So just before coming on today, I looked to see what's happened. So just as a reminder, we started on about 20 contacts per month. In June, there were only 2 contacts with this patient. And in July so far, on the 29th of July, we've had no contact. So not only are they able to provide that service to patients, they're also reducing our workload. It's worth remembering that so much of what we care for in primary care has a psychosocial basis. And unfortunately, a lot of it we don't have time for in our clinical consultations. We just need to make sure that we refer them to the appropriate specialities or the appropriate services. So time went by, we started hiring more staff, and also my PCN was involved in the COVID vaccine delivery. So at that same time, we hired a care coordinator. For me, I think care coordinators, I think it's been highlighted so beautifully. They have a huge role, and it's important to make sure that we use them in all those roles. So for example, in our area, we're using them for integrated care management roles. We're also in all our PCN DESs, we're making sure they're critical to all of those roles. For example, for our pharmacists, they do the structured medication reviews, but the care coordinator can help them pull out those patients. For a learning disability check, they've been done by a physician's associate. But again, just like the previous speaker, we'll get the care coordinator to call the patients or call the family members of the patients, trying to tell them that this is what's going to happen and book them an appointment. So in terms of learning disability health checks, I think 4 of our practices since April of this year have carried out all our learning disability health checks. The other 5th practice is well on the way. This is a massive improvement from last year. And that's because our personalised care roles staff are all working together so well. We know there's a huge number of patients with backlogs from secondary care, and also we're dealing with more and more multi-morbidity. So I think MDTs are going to be really crucial for us going forward, and I think this is where the care coordinators will actually be in their own place, because they will really be able to make a significant difference. Again, health and wellbeing coaches, we've heard about it, so I'm not going to say much more about it. Our health and wellbeing coach also has an interest in mental health problems. Her degree was actually in psychology. So actually, she's able to provide a lot of support to our patients. In addition to health and wellbeing and motivational interviewing, she's also able to provide some psychological support as well. In terms of health and wellbeing, it's worth remembering, since COVID, the average weight gain has been ½ a stone. So huge problems for us for the future. And I think the 3 roles are going to make a significant difference. So top tips. Number 1, if you haven't hired them, try them, because you'll find the benefits. I was speaking to one of my colleagues recently, and she said, we don't know how we managed without them. That's the difference they've made. Now, when you're going to hire social prescribers, I would suggest link in with a local authority who already have some social prescribers. Hopefully they can help you with the training, regular updates, and hopefully even with the appointments. Number 2, integrate them not just within PCN, but within the practices as well. So they need to have access to the IT system. They need to be able to record their consultations within the IT system. So in the past, when we referred patients to social prescribers, we would refer them and maybe never get anything back, or get something back a few months later to say, this is what's happened. This way, I actually write down something in my EMIS records. I actually book them a patient directly, and tell them they will be called by a social prescriber. And the next time I go into the record, I can see what's happened. I think that's crucial. The next thing is, it's important not just hiring them, but we've also got to retain staff. I know all of us working in London know the difficulty of retaining staff. And I think the 2 important things here are, number 1, team building, and number 2, regular updates. So for our personalised care staff, they have relatively regular sessions where they'll sit together, look at what they're doing, share best practice, as well as hopefully look at what they can do for the future. And for our clinical staff, I know we're not talking about our clinical staff today, but for our clinical staff, we do something very similar. So I'll do a regular clinical update for them. We'll choose a session, diabetes or something, and we'll have all the staff who are involved in that available for that. Other important things, number 1, think about developing templates. So we've developed a template for our health and social worker. In addition, we're also looking for our social prescribers to develop a template. I think it's important that when they are seeing these patients, it's an easy access for them. We can make sure that all the important things are documented and it's useful for auditing purposes for the future. Next one, encourage cross referrals between all your ARRS staff. So when we're developing services, one of the things we like to do is to give ownership of the services to the staff. So when something new comes out, for example, we know care homes is part of the DES, but also locally we have an SNS on it. So rather than the clinicians, me deciding it, what I'll do is I'll say to the staff, I'll say to our particular ARRS staff, I'd like you to do it. I want them to go away and develop those services, and also think about cross referrals. So for example, our care homes will find the care coordinator will make sure that all the care homes are visited or have that discussion. The physician's associate will actually do those consultations. They can then refer to our first point practitioner or our dietitian as necessary. So we're trying to provide a holistic approach. And finally, I would say that for the practices, think about developing a template which has a list of all the roles that you have within your PCN and what things they can refer to. So for example, we have a template which will show the name of the staff, what days they work, how to book them appointments, do they do remote consultations, will they be on site, and if they're going to refer, for example, if they're going to refer to a pharmacist for an SMR, how long does that take? And when they think, why does it take so long? After the SMR, it will say, these are the things that will be covered in the SMR. If they're going to refer to a PA for a pill check, how long should that consultation be? The important thing is they've got to be a part of the whole practice team. I can't speak more highly of them. I think they've actually transformed the way we provide care, actually. So with that, I'll hand back to Leona.
This is great. Thank you so much. There's a really quick question. I don't know if you can answer this in a minute, but someone's asking about the prep that you did before the roles are coming in, and I think this is, I hear this a lot. You know, that actually link workers are coming into a system where the thinking is then rested on them in terms of how they should work. What preparation did you do before these roles came in?
So in terms of our social prescribers, we're very fortunate in Waltham Forest. We have a lady whose name I saw on the chat earlier, or saw on the list of participants earlier, whose name's Sharon Huna, who actually runs our local social prescribing service in Waltham Forest. She's been incredible in that she helps us both in terms of recruitment, appointment, and training. So but for all the other staff, what we do is initially they'll have a 2-week induction. We're a training practice, and all training practices will know when somebody new starts, they will come in and they will have a 2-week induction. And during that induction, they will learn about the health system. So we have people who've worked in primary care before. We have people who's their first job in primary care. They will learn about EMIS. They may have never used an IT system before. And at that stage, they will get to hopefully meet all the members of that particular practice. And then if we have more than one, for example, if we have a pharmacist, or for example, we have 2 PAs. If we hire another PA, what they will then do is they will then shadow and visit all the other practices and have an induction with all the other practices. They'll have access to all the resources, they'll have access to all the training, and we'll link them in with our training hub to make sure they have peer support as well.
Such an important reference. I know the training hubs are all at varying levels of maturity, but I would recommend anybody that's thinking about implementing these roles to reach out to their training hub to see what support they can offer. I think the other thing to mention is from the things I've heard, it's really important to do some thinking before and have a bit of a plan. You may have to revise that plan. Thank you so much. We will be sharing all of the resources that have been referenced in today's session with the slides afterwards. We're going to hand over to, I'd like to go to Mohan, who had another example. We're hugely behind time, so I'm just going to ask Mohan if he's got any top tips. I know that in addition to some of the things that Dr Noede has referenced.
Thanks, Leona. Yeah, I'll cut it very short. I won't go through some of the examples which I've had. I think Noede's gone through quite a lot already, which is great. And yes, I think the 3 roles, we've had social prescribing for coming up to 5 years now. And we've had health and wellbeing coaches and care coordinators for 6 months, and they've integrated really, really well. And And I think my top tip is that pre-planning, identifying everyone knows what their roles are and they all know what each other are doing. And my definition of both those, there is a bit of overlap. Social prescribing, looking more at the social issues and social deprivation or social causes which affect someone's health and well-being, and connecting to the community. That's not a strict definition, but that's my way of explaining it. I think the health and well-being coach is looking at that individual person in front of them, looking at their long-term condition and what matters to them in terms of how can they improve their health and well-being, or how can they improve their long-term condition. And I think if you get that clear, that helps sort of identify where the roles fit and how you can cross between the two. An amazing event we had sort of about 2 months ago. We've got 3 health wellbeing coaches in our network, and Caroline's one of them. And Caroline and Sally did a webinar to all the staff in our network. So we had, I think, 40 odd turn up, and we did a health and wellbeing for staff. And so it's been an awful year for a number of reasons. And actually, they gave some tips around how they can help themselves, and that was really nicely received. So I think that's something where you're utilising your assets to actually help your own network itself, not looking at individual cases, because that can be not quite right, but I think looking at it on a generalistic view where you can utilise that. So that was really, really helpful. The care coordinators we're using for our blood pressure at home work, and that's again very powerful. And they can also, as people have said, be a first port of call in order to link in to some of the interventions, health wellbeing coach and medical team, and then also connect with them afterwards as well. So if they need a 3-month or 6-month review afterwards, the care coordinator can then coordinate what to do with that particular individual. So lots to do. And finally, I just want to mention, which hasn't been mentioned, long COVID. So a lot of patients, 80% of patients with long COVID don't necessarily need a hospital intervention, but actually have some kind of support which is required for them. And I think these are a huge resource. All the roles, in particular social prescribers, who can help some of the social issues which have been developed as a result of long COVID. And actually, there was one more thing, video group consulting as well. Again, a massive opportunity for all these roles to try and drive that through. And we're getting our care coordinator to try and get that going here in our network. Thank you. They're my top tips. Thank you, Leanna.
Yeah, and I hear that project, the last one that you've just referenced, they're working very closely with the health and wellbeing coach on that, which is these are examples of how these roles can be supporting each other by working together as part of a team, to ensure that they're not isolated in these new ways of working in primary care whilst everybody's extremely stretched at the moment. If we could go to the next slide. I'm going to rattle through this because we're really out of time. I think you probably know, most of you will know about Healthy London Partnership and the role we're playing in supporting the system across London and convening a multi-sector partnership to support, develop and innovate social prescribing. If we could go to the next slide. Healthy London Partnerships also sort of hosting and building the capacity of some of the regional associates. I am one supporting the social prescribers across London. I run a number of peer supports and webinars to support link workers in their role. We've also got health and wellbeing coaches. Caroline Haynes, who spoke earlier, is one of the new regional mentors supporting health and wellbeing coaches, and she will be doing a piece of work to map health and wellbeing coaches over the coming weeks. So if you are a health and wellbeing coach, or you know of a health and wellbeing coach, please ask them to complete this form. I've put a QR code there as well. Again, we'll be circulating all of these slides after this session. There will be some, next slide please, there'll be some roles coming into the system who are going to be supporting, doing the same role to support care coordinators. We're just waiting to confirm who will be taking that post. And we also will hopefully have a really fantastic team of people that are going to be supporting the development of primary care in PCNs. That PCN advisor hopefully will comprise of a GP, also a training hub lead, and a project support to make sure that we're doing some really fun and innovative projects to support PCNs in implementing and embedding these 3 roles. I'm going to hand back to Mohan, who can explain a little bit more about his role as a personalised care clinical lead and what some of those are doing across London. If we go to the next slide, please.
Yeah, so there's 5 clinical leads across London supporting personalised care. The next slide has different names, and effectively I think it's providing steer in terms of what good practice is going on and what support may be required. And good examples of that may be a formal network with all the network leads, also the borough leads as well, and also an informal network where you connect with anyone who has an interest in personalised care, and that's really powerful to be able to support that as well. I know in North Central, Katie Coleman, who's a lead up there, is doing fantastic work around setting up a board where she's got different members who are being champions for personalised care and supporting the particular borough and the particular ICS. So I think any sort of questions you may have or any steer you may need, then please do contact your local ICS lead. I think the next slide goes through that, and this slide deck will be passed out. So yeah, I think that's really it. Thank you, Leanna.
I think it's important to say there probably are quite a lot of people doing something similar, and Mohan and I were talking about, you know, how do you know whether or not to go out to your personalised care clinical lead or the PCN advisor? And what we were thinking was it's important to reach out to both at the same time. Probably we're all going to be working as part of a team with some of the ICS representatives as well for personalised care or for primary care or even for primary care development. So there are lots of people doing work in these fields, and the important thing is that we're building capacity and working collaboratively rather than duplicating. Thanks, Mohan. Was there anything you wanted to add to that? Sorry.
No, just put my camera on, but yeah, that's all good.
Yeah, great. So we'll go to the, if we could go back to the first slide actually, because I think we've not actually got a list of all the people, sorry, and the resource pack is not finished, but we will be finishing that to send out to you afterwards. So going to the Q&A, I think there's Mohan's also going to be supporting in this. I'm looking at the questions that we've got from Slido. It seems there's a real interest in how we support the misuse of social prescribers. We're coming out of COVID at the moment, and link workers, their role has been repurposed to a certain extent. And how do we make sure that link workers are getting back to the work of social prescribing? Any of the panel want to jump in on this? Jagan, I know this is something you feel quite passionately about.
Yeah, thank you, Leanna. So we as with everything, most of us, everyone actually, has been kind of repurposed to kind of support whether it be a vaccination or whether it be supporting the recovery of the elective work in the hospitals, or getting, you know, people who are, you know, the most vulnerable or the hard to reach group, and using social prescribing link workers to kind of help support some of those conversations for vaccination going forward. But I think we're at a stage now where, as things start getting back into some kind of normality, it's about using the link workers really, you know, who are very passionate people, really great people, a lot to learn from them. I always say, you know, I always learn something from my link worker, and it's about getting them into the role that they were designed to do, to help not only support your patients and residents, but also help some of that delivery going forward. And they are fantastic assets. Don't underestimate them. You've got to give them time to, you know, grow within your PCN, give them time to. And what was really interesting, the most developed PCNs up and down the country, they actually give you really good feedback on some of the gaps in services. And I certainly, as a commissioning side and as a chair for North East London, actually some of the link worker stuff that we get back is so revealing. You know, there are people saying, well, why are we using link workers for doing this, this and this? Because there are gaps, because we haven't really, you know, we in North East London, we looked at children and young people, is because we haven't really got it great for accessing, for example, mental health support for children and young people. And the link worker is part of that preventative strategy for London. You know, it's about intervening early, getting the support, using the assets of not only, the community, but actually using the greatest asset is the individual people. which is where, you know, that's what it's all about. And that's, you know, and empowering people to give them the ability to start thinking about some of the things they can do for themselves. So I think, you know, it's been a hard 18 months, you know, and I'm not suggesting I certainly are fed up of the pandemic, but, you know, we are where we are. And I think let's get our link workers and our health and wellbeing coaches and our care coordinators really get to use them really effectively. And I think all I would say is, you know, they need your support as PCNCDs. They need the support of the practices and the staff. And certainly from an ICS, and Mohan is, you know, one of our ICS leads for South West London. You know, we as CCGs and ICSs, we're very keen to support anything that you might have to say, or some of the difficulties. We know it's tough out there, but let's use them to the best we can, and you'll be surprised what kind of goal or what kind of things you'll do. There's some fantastic, real good news stories of some of the things that we've done across London, and of course nationally. You know, Nick has talked about things that have been, you know, people are doing up and down the country. Lots to learn from each other. But thank you, Leanna.
Nick, is there something you wanted to come in on as well?
I think just that there, you know, there's a new national evaluation that will be starting around looking at the effectiveness of social prescribing link worker services. But I think, and that's to sort of help with our learning going forwards. But all the studies that have been done so far say that the value of this role is because they have time to get alongside people who've got complex issues in their lives. So not a 15-minute appointment, you know, really getting alongside people and to get to know the local community. I remember on one of the calls, somebody referred to their link worker, I think it was up in the northeast, as almost like a taxi driver in terms of the knowledge of their local, you know, what's all the different community groups and support that's out there. So really acting as that bridge for the PCN with the community and building those links up. So I just think we've really got to rebuild the role if we're going to make the most of, you know, what it was intended to. And I think when you think about COVID and how it's really exposed the health inequalities, and that's why we need a much more proactive outreach and targeted approach to social prescribing. But also, all of us have learned during the pandemic the value of nature, you know, of the things that give us purpose and enjoyment and improve our health and well-being, such as the arts and sports as well. So, you know, certainly for people with long-term conditions, that can be really, really valuable. So that, yeah, it's about recovery and restoration for those roles so that we don't miss the opportunity that we have with the additional roles funding to really make a difference to our local communities and reduce pressure on GPs. And I loved hearing from the GP who talked about how these roles can help the other additional roles. So I think you think of the interface with the link worker with your mental health workers or your OTs or your community pharmacists, you know, many, many ways they can add value.
Very well said. I think one of the other questions that's coming up in terms of what can be in place for a link worker to be integrated and embedded within their PCNs, I think it relates to some of the questions that are coming up around training and support and how they should be supported in their roles. They're all related. Mohan, is there anything that you can speak to from how these roles have been implemented in your own PCN, some of the thinking that has gone on before and the support that your PCN is providing these additional roles?
Yeah, so I think we're a fabulous opportunity as we've all sort of agreed. And I think now that we've all got over 1,000 link workers across the UK, we've got them really nicely embedded in all these practices and all these networks. They've really opened the door for... Your
sound is coming in and out. If you could just get a tiny bit closer to your...
Oh, is it?
To your computer, sorry.
Must be something in our practice. Happened to Caroline, didn't it, as well? I think our IT is not great. Is that better? Yeah, okay.
Perfect.
What was I saying? So yeah, so now that every practice and networks also have link workers, it's a really nice sort of infrastructure on what to build upon. We've got a nice base level. A year ago, we were still struggling to get that baseline. Now that we're there, the link workers have opened the door for the other allied roles, the health wellbeing coaches and care coordinators, and we need to really ensure that we support all those. In terms of how do you make sure that we can integrate it well and induct well, I think it's pre-planning. It's like with all roles, we need to make sure the environment's well, the training environment, people are pre-planned before they come along. They're then supported during their sort of while they're at the practice, and we improve retention. So things like supervision, things like evaluation as well, making sure that practitioners who weren't on board for GPs who didn't quite understand it, they can see the evidence and see how it's affecting them. These all things will help and drive it forward. So there'll be my top tips about pre-planning, ensuring when they get into ensuring that you continue your retention, and then evaluate it for your own purpose, but also for the rest of practice and network. Thanks.
Jagan's nodding. There's a few people in the room nodding. Is Janie still online? Because I know they're doing some really fab stuff in terms of supporting their link workers in Barnsley.
I am, yeah, sorry.
Yeah, hi. I'm trying to spotlight you, but I can't find you. Yeah, do you have, we're just talking about how these additional roles are being supported within their practice, and how best to embed them.
Our link workers is slightly different, because in Barnsley we've been quite lucky. We've got our housing association already has a social prescribing service, so we tailored ours to young people. So our social prescribing service works with senior school sort of age children, so anybody over the age of 11 till maybe 19, 20. We work very closely with our local CAMs, our early help service, and we're linking to, we have drop-in sessions in schools. The link workers have got support of the other services, so we do, so early help, we sit on their early help panel, so they have quite a lot of support. They all attend peer support sessions, and we just put them all through the social prescribing qualification as well.
When we talked, you spoke about kind of all of the roles getting regular one-to-ones.
I have regular one-to-ones with all our link workers monthly. They have team meetings weekly. They all come in, although they work agile, they all come into the office for at least 2 hours a week, so they can sort of talk about cases and build up that experience from one another, and they all attend regional peer support as well.
And the health and wellbeing coaches run their own fortnightly peer supervision.
They do, yeah.
Which I think is great, and I think it's thinking about how we can empower some of our workforce to set up some of these structures themselves. And I think this is where there's some really good examples of the training hubs supporting social prescribing and some of the additional roles in places like Newham and Barnet. We've got the training hub facilitating link workers and link worker managers, training GPs around the kind of role they're doing and the support that they need, and what they're looking for from clinical supervision, which I think is really important to bring link workers into the conversation around and health and wellbeing coaches and care coordinators around the support that is needed. Mohan, do you want to come in on one of the questions that's in the chat box? I think this is...
Yeah, it was just about how it was kind of how would you do the strategically engage before the kind of network? I was just explaining that.
Your sound is not great.
You know, I've written it down. I also mentioned it when I spoke. So.
Oh, great. Okay, fine. One of the other questions that's coming up the charts, and for those of you that aren't on Slido, if you want to jump on to try and vote in the last question that we ask, there's a huge resource required to support these new roles in terms of management and admin. And I think definitely I hear sometimes there's not enough money, there's not enough resource, there's link workers don't have the right tech, perhaps they're not being paid enough money. And then on the other side of things, we've got big costs in terms of management and making sure that they are being invested in and supported. Is there anything coming online to support this? And I wonder if I could go to Nick you're on mute.
Sorry, I'm really sorry, Leanna. I was answering something in the chat. Can you take the question again?
No, it was just a reflection really on the huge resource that's required to support these new roles coming in terms of management and admin, and if there was anything being planned. I guess we can come to Jagan after this at sort of the ICS level, but is there anything coming online to support this? I can certainly speak to what's happening pan London.
Yes, so nationally, there's a lot of work going on to support around supervision and training and development. So if I just talk about those two sort of initiatives, so for supervision, we commissioned RCGP to do a piece of work and provide some group supervision, action learning supervision, which seems to have been really, really effective and very, very popular. And from that, we're developing a module on what does good supervision look like? Because I think people get really confused about, what is it? So having a named GP is one thing, but actually what we talk about, it's in the DES, it's referred to as clinical supervision. That's not quite the right term, because it's more practice supervision, but it's about that psychological safety, working at the boundaries of your practice, that sort of thing. So we're developing a module that will be available, HE accredited module like the others, on supervision. We're also looking for, we're calling them supervision trailblazers, so an ICS in each region that we can give a bit of money to help with spread and scale across the regions. We're also going to be updating our reference guide to include better practice around supervision and support, and we've done various modules and things. So we're trying to sort of get the infrastructure, but in addition to that, what we're really looking at and looking for is how the ICSs, and this is why it's so fantastic you've got Mohan and others as ICS leaders, can take that ICS perspective to say, looking at quality improvement of social prescribing and these other roles, and to look at how you can work together with training hubs and across PCNs to be able to meet the needs that are required around training and development. Training and development, we've got the accredited modules. We've got 9 now accredited modules for link workers, which are all free. There's a fortnightly webinar. We really encourage people to access this, and we do have a welcome pack and a pack for ICSs that sets this out. But we're also exploring what's the potential for a professional register for each of these 3 roles, or certification. So we never ever want to stop people being able to come into these roles, because part of their value is they can come, it could be because of your lived experience or coming from particular communities, it's a great entry point. But what we do want is, we've got the competency framework, which has just been refreshed, and we want to be able to sort of start to look at accredited training for link workers and for the other roles.
I wanted to mention here at this point as well the additional roles that are coming on stream. So the personalised care, the PCN advisor roles, who will be working alongside the clinical leads and the ICSs to identify PCNs that are wanting to implement these 3 roles and to get some support. We'll be doing hopefully some pan London events. We'll be going into local systems and actually wanting. It's really important that these roles are supporting health inequalities in our recovery in London, and being able to target areas of particularly high deprivation where capacity in local surgeries and local PCNs is stretched. We'd really like to make sure that these roles are building capacity in those areas, so we can do some of the thinking and sort of direct support there, and hopefully scale outwards. Jagan, is there anything you wanted to add to that?
Not really, but I think there's certainly a large amount of support for, and I don't want to kind of give everyone the details, but there's a huge amount of support. If you just reach out to your clinical leads within your system, Mohan for Southwest, and you've got Ruchira for Southeast, Nilesh for Northwest, myself and Ben Molyneux for Northeast, and North Central is Katie. Very happy to have a conversation about what additional support there is. There are differences. I know that we as a system in Northeast have invested quite a bit of support in terms of training, as well as also some other additional things like equipment and things like this to support our link workers, and as Nick said earlier, there is a lot of national support, so which are drawing in the fantastic resource from the national, as well as things that have been commissioned centrally. So sometimes you just don't realise how much support there is. I think just reach out. You'd be surprised what you might find. And if there are things that we can help with, I'm sure we're very happy to, not only through the ICSs, but also from a regional point of view, very happy to kind of have a look at going forward. And you know what they say, if you don't ask, you don't get. And I say just ask, and we're very happy to look at it. And just remember, you've got some fantastic advocates. I'm a loudmouth, I just talk about it, but there are some real quiet people who've just been getting on with the work and who've done really fantastic work. You've heard some of those, our health and wellbeing coaches just do it. They just do it, and they're fantastic. Just reach out to the local BCNs that have got staff. You'd be surprised how well they've, just done things, and social prescribing link workers and so on. And we're always happy to kind of, link people across the system. But yeah, Leanna, I'm very happy to take things offline if people need extra kind of support.
I think it's worth saying that the work has been focused on supporting, or some of the associate work has been supporting link workers and the system to connect. And I think there's some great people in the room here, and I think it's the start of a community of practice of PCN staff who really want to think about how to use these roles in innovative and impactful ways. So we'll be picking that up. We're hoping to have a check back in 6 months' time to see where everyone's at, to look at some other new examples, some new learnings. And I'm imagining that each of the ICSs is doing something slightly different, but there will be things happening in your local systems over the next 6 months. So get involved, join those discussions, and what your neighbours are doing is going to have an impact on perhaps on what you might do as well. So get to know your neighbours. There's also going to be a session we'll do a focus session for the people on the front line as well in the next 3 to 6 months. So look out for that, Pan London. A big thank you to all of our speakers today. It's been really interesting to hear from different bits of London, and hopefully this will be the start of us uncovering pockets of best practice and thinking about how we can pollinate it across London and connect you all in a way that can really develop your work. I'm going to be sending out a follow-up with the recording, the resources, and a feedback form. If you could spare 5 minutes to complete that, it would be really helpful. Any last comments from anybody?
Can I just say one thing, Leanna? Don't underestimate how much these personalised care roles support the practice. You'll be surprised that all my staff in my practice have all been through the health and wellbeing coach for support with their own health needs. We've now changed our adverts when we put out staff to say you'll actually get a bit of support from our health and wellbeing coach and social prescribers, and you'll be surprised that for some reason, I still didn't know why, but we seem to get more applications. So there's something there that people do. So don't underestimate. And in the pandemic, these 3 staff members have been absolutely fantastic for supporting not only our staff, but also the GPs and then our clinical staff as well. So they really do fit that unit. So, they are really our assets of the team going forward. So I just wanted to raise that.
Thanks so much. Thanks to you all. Look at that, we finished 2 on the dot. That might be the first time in my life.